Well, good morning, good afternoon, and good evening, everyone. Thank you for joining us for our November of 2022 Global One Health Initiative webinar supported by the NIH Validity International Center. Today, we are very excited to hear from our own Ohio State University Global One Health LLC Country Director in Ethiopia, Dr. Ebba Abate, presenting the Ethiopian Public Health emergency response to COVID-19 challenges, successes, and future considerations. And he is here with us today in Columbus personally. We're very excited about that. And Dr. Ebba is a biomedical expert who took his PhD in medical microbiology in June of 2013 from Linköping University in Sweden. I think I said that right. And he worked at the University of Gondar in Ethiopia for more than 15 years, where he served involved with systems. In 2017, Dr. Abate was appointed by the government of Ethiopia to serve as Director General of the Ethiopian Public Health Institute, or GOHi, which is the National Public Health Institute and the most influential public health research institute in Ethiopia. It's similar to the equivalent of the Center for Disease Controls and Prevention here in the United States. Having more than 1,200 employees, EPHI undertakes research on priority health and nutrition issues, coordinates and manages the national public health emergency system, and carries out referral diagnostics and analytical laboratory tasks. During his time as Director General, Dr. Abate was able to make improvements in the areas of public health emergency management, national laboratory systems building, and evidence generation systems. And Dr. Abate also successfully led the national COVID-19 response, and together with his team, established the National Data Management Center at EPHI, aimed to support evidence-based decision-making in Ethiopia. Dr. Abate also produced more than 65 or has produced more than 65 publications in peer-reviewed journals and has been the recipient of numerous research grants from organizations such as the World Health Organization, U.S. Centers for Disease Control and Prevention, European and Developing Countries Clinical Trials Partnership, Swedish Research Council, Swedish International Development Cooperation Agency, Brigham Young Foundation, University of Gondar, and the Armor Hansen Research Institute. He's also received numerous awards, such as the Torre Godel Prize for Outstanding Young Research in Ethiopia, as well as a personal recognition and award from the Ethiopian Minister of Health and the Director General of the World Health Organization, Dr. Tedros Adhanom, among other recognitions. And in May of 2021, Dr. Abate joined the Ohio State University affiliated entity Global One Health LLC in Addis Ababa as a technical director and was promoted to his current role of country director in May of 2022. Under his current role, he leads the Global One Health LLC team to carry out on-the-ground implementation and collaborative support in areas such as human resource development, system strengthening, and research to the Ministry of Health, Ministry of Agriculture, EPHI, Ethiopian Food and Drug Authority, Armor Hansen Research Institute, and regional health bureaus and facilities through various joint collaborative projects and capacity building schemes. We're so excited to have you here with us today in person, Dr. Ebba. As a reminder to the audience, we will take questions after Dr. Ebba presents via the Q&A box. And I will go ahead and share your PowerPoint and hand it over to you, Dr. Ebba. One moment here. Good.
Thank you so much, Laura, for the warm welcome and introduction. As Laura indicated, my topic of talk today is the COVID-19 national response in Ethiopia. Just to share, the sector challenges and areas for future considerations. Maybe most of you might know about Ethiopia, but it would be good at least to say a few points. Assumption that there are individuals who might have limited information about the country. Ethiopia is the third most populous country in the world, and the second highly populous country in Africa, next to Nigeria. And in terms of size, the country is almost 5 times higher than the Great Britain. And the GDP is these days a little bit more than 111 billion. At least it's not in Africa more than this. My modest one, but the big reporter was, the US, if I'm not wrong, it's roughly 3 trillion university. And Ethiopia is considered as a hub for different international diplomatic communities, including seats for different big international organizations like African Union, ESA, Economic Cooperation for Africa, and other institutes and embassies. And Addis Ababa is considered as the self diplomatic hub in the world next to New York and Geneva. And when we talk about the health system of Ethiopia is following 3-tier system, and it's mainly governed by the Ethiopians. Since the core point of discussion for today is public health emergency, and this role, especially the technical undertakings for this one, is given to the Ethiopian Public Health Institute. Ethiopia is also the origin of mankind, about Lucy, and also the recent discoveries of hominid, more than 4.5 millions of years. Ancient history almost dates back more than 3,000 years of age, and different landscapes, histories, including almost more than 25 mountains with an history of about 4,000 about sea levels, and including the country is having also the lowest depression on Earth, which is a climatic depression, having a low, the 120 meters below sea level. And coffee is a big thing for us. We are using that for many purposes, for social, economic, and others, including the ceremonies that we are showing by having coffee. You can clearly see how President Obama interacts with the Ethiopian mother during his visit in Ethiopia, and diplomatic relations between Ethiopia and US gets back almost more than 100 years. And these are the critical areas that I want to address in my talk today. The first one is to at least reveal, the burden of COVID-19 in countries like Ethiopia, representing, various countries in Africa and other countries elsewhere with the same economic and social strata, and how we also the country manage COVID-19 response. As we know, COVID is a big threat for every country on Earth, and it has also caused economic, social, and health impact. We also share at least our experience on how we overcome these challenges. And the most important thing is what really have we achieved in the course of the COVID response. And lesson learned from this journey, obviously each country has its own experience that one could exploit from this, and eventually also what is to be done. Considering the COVID experience, with them is the areas that I want to highlight. Maybe when we discuss about COVID, there is a need at least to know the baseline. Otherwise, that would not give you a good at least picture, because each country has its own limitation and strengths, and would at least to highlight at least some of the limitation from the Ethiopia side. as we all know, the Ethiopia is a resource limited country, having got many priorities, like, what you have seen as in the picture. So COVID is one thing, but there are also many other priorities and health problems and other problems in the country. So COVID came while having this kind of challenges and problems. Health literacy is in infantile stage, I would say. So there is at least a lot to learn to overcome at least said problems. Security and political instability was there. As you know, we are also in this turmoil since previous period, and the new government also has taken, the position during the time COVID came to us. So that would be considered as one factor, and shortage of trained human power is also one factor, as we checked by other developing countries. The public health emergency management system and its operation level gaps are also infantile stage, I would say, considering the size, the population size, and also the geography and its complexity into account. Maybe the last one are, having a world-class airline and political and diplomatic hub. Maybe literally it seems, an advantage, but when it comes to COVID, it will be also considered as a threat, because you have a world-class airline having more than 100 destinations. You can at least recall, the challenge during the first phase of COVID. There were many countries, banned travel and other restrictions, and having of an airline flying more than 100 destinations would cause also, a big threat for the countries. But we systematically use that potential positively in the course of COVID sports. And the political and diplomatic hub, because there is also a significant travel of development communities that have also its own threat in the importation of COVID as well. So this is some of the key figures where we are globally. So roughly more than 500 million cases are reported globally, and I think recently the global population has reached at least 8 billion. So roughly 8% of the global population have been infected by COVID, and 6.6 million people have died globally. So it's not a small number, which is almost equivalent to the population of artist states. Coming to Ethiopia, roughly close to 500,000 cases have been reported until yesterday. And from this, we count roughly more than 7,000 cases. And the recovery rate is quite promising. And as we speak, we managed at least to roll out 53 million vaccinations all over Ethiopia. But in terms of the number of individuals who have got the full dose of vaccinations, we have reached at least 3 million. So this is not a small number, and I'm sure the upcoming campaign will also uplift the figure. And maybe the core point is not showing the COVID response as it is, but the whole purpose is what we have learned from this. And I think this will be also a critical example how the investment that we will make at certain point would help, if something would happen, in due course. So just before COVID picture, we have done, significant development and capacity building activity in the public health emergency management system in Ethiopia at GOHi as well as in regions. For example, in the last 4 or 5 years, 4 years, I would say, because this is undertaking done just 1 or 2 years before COVID came to the picture. So we are having just 28 individuals working on the public health emergency management at GOHi. So we almost, significantly increase that number almost to 200 staffs. So you can see at least a significant increment. And we were having just one directorate managing the public health emergency system at GOHi. We at least increased that to 5 divisions, significant number, and established the national emergency operating centers. We didn't know about EOC almost before COVID, 1 or 2 years before, but thanks for US CDC, We sent, a few folks, 2 individuals to Atlanta, took the training, came back to Ethiopia and built the first national use at GOHi. And by the same token, we have also expanded that to the region. So we critically use that capacity during COVID response. And we also increased, the COVID response, control sites, border control sites from 15 to 35. And resource mobilization is also a very important thing that we have done before COVID, because roughly the annual budget, both from the treasury as well as from partners mobilized for the public health emergency system is roughly less than $1 million USD. But based on the discussion, the firm discussion we had with the ministry and others, we managed to enhance this mobilization of finance to 12 million USD, and we used that to enhance both the capacity at GOHi and also in the regions. And regional and sub-regional FEM has been also strengthened, HR development, logistics, including the procurement of more than 300 motorbike and distributed to all waradas, and also some regional offices. And alignment was also something that we need to undertake, because there were, engagement of different partners haphazardly, but response shouldn't be done like that. So we at least bring all on the same page under the leadership of GOHi. And this and others, I think, helped when we initiated the COVID response later on. So these are, the structures that we initiated the moment we have heard about COVID. I think luckily we were doing some activities also, especially at border controls to prevent, Ebola at that time, because there were also cases in the Democratic Republic of Congo. And what we did was we enhanced, that effort. So we established, at least 3 critical platforms. The first one is high level, which is led by the Prime Minister, and sometimes, later on, the Deputy Prime Minister has taken the roles. And the task force to align other line ministries led by the Minister of Health. And the technical operations on the ground has been led by GOHi, by the leadership of the GOHi DG. And there are also different technical working groups that GOHi is monitoring. So these are, I think, some of the points that I want to share in the subsequent slides. The need at least to impose state of emergency, how we enhance the multi-sectoral response, and the surveillance part. Here for surveillance, it's not a simple surveillance. As you know, Ethiopia is having more than 110 million of inhabitants, but there needs to have a special means to address at least millions of houses, and we use different tactics to use that to reach that. And just for example, in a month period, we have reached out almost 10 million households, meaning at least if we count at least 3 or 4 individuals per house, we manage at least to reach out a little bit, half of the population of Ethiopia in a month period with a massive operation. So, and the lab testing, facility readiness, and HR development, resource mobilizations are, some of the highlights that I may touch. And state of emergency, as you know, the COVID response shouldn't be addressed through the conventional rules, regulations, laws that we have. So for that, we at least impose, this regulation, and it has, several components and restrictions, avoiding of, gathering 4 or more than, and transportation to carry on only with 50%, in some cases 25%. This might be, a simple number, especially in US, where most of the individuals have their own car. But that's, a big challenge in Ethiopia, where the majority of the, the public use, public transportation, not only getting of service, but also most of the individuals would get, the daily bread through this, services. So it's really very challenging when we at least translate those things in place like Ethiopia. Social, religious, and public gathering. This seems, very simple, but Ethiopia, especially when it comes to religious, it's a little bit conservative, and having of, a big say on that. And I would say in the history of Ethiopia, to my knowledge, at least this might be, I mean, the only time the religious places were closed, both, the Christian, sect and also the Muslim sect, for sake of COVID. And it was a tough time to convince that, starting the leaders, the religious leaders, to the public, but we managed that, and that also has resulted significant impact in managing COVID response. And closure of high business, school and universities were closed. Actually, we also used, the available infrastructures for the response, because universities were also used as, at least as a hospital in some places, and also a quarantine site in many places as well. And as I said earlier, multi-sectoral response is very critical, especially for countries like Ethiopia, where resource mobilization and alignment, starting from the higher leadership, is very critical. And for that, ministerial committee have been established by the higher leadership of the government, and also mobilization of and establishment of different platform, engaging community leaders, religious and civic societies and private sectors are also something that we could at least say on. And this engaging the leadership is very critical, as I said, for many reasons. We need to mobilize finance. It's very important to have high leadership, and political decisions need to be also laid down. And for that, we need also to have, the higher leadership. And we used that, significantly somehow. You can say at least the visit of the Deputy Prime Minister at frequent interval at the Ethiopian Public Health Institute, and how we are also efficiently doing things at the Bole International Airport, and also introduction of at least some new ways of greeting as well, because in Ethiopia handshaking is quite common, and but we introduced at least such kind of shaking and greetings with the aim at least to minimize the transmission. And the House of Parliament members are also critically evaluating, following, and also supporting our move. You can see also the visit at spot at the Bole International Airport, the different ministers and key individuals from the Prime Minister office, including also Dr. John Kengson. He was at that time the director for African CDC. Currently, he is the global PEPFAR coordinator and special representative for health diplomacy, who nominated by the US president. So we tried to engage, all potential partners in all those response. And risk communication is very critical, especially when it comes to emergency management. There is a need to build, public trust, and there is a need to convey information timely to societies and to everyone, and that would have its own positive impact. And our awareness creation and reaching out of the media were also one of the critical things that we did during COVID response that resulted, to build public trust. And I remember the Ohio State Global One Health GOHi did, assessment that would also at least indicate the perception of, the society towards the COVID response in Ethiopia. And one of the things the response was, most, responders built, trust and credibility for the Ethiopian Public Health Institute for what we are doing, engaging the community. So reaching out the public were something that we also share as a good experience. Yes, after several months of follow-up on March 13, we came out with the first cases, and the case was also at least passed to the public with live transmission, and that would also give a sense that there is no any secret that the government entity would make when it comes to COVID response, and that, as I said earlier, lifted the public trust. innovation you can interpret in different ways, high tech, low tech, but at least with the available resource, the community have tried, to be innovative. So we could question, its impact, but at least you can see at least two pictures. That picture is taken from the one area, rural area, from Muslim community, and how at least they tried to avoid, physical distance. Proximity and through physical distancing, and you can see at least how they are innovative and do the business without, interruption. And you can at least see the other picture, the priest, especially in the usually individuals who are close to religion, a little bit, tough to adhere for certain rules, but that was not the case during COVID response. And you can see innovation at different point with the aim at least to minimize, the effect. And development of different protocols, guidelines are also considered as part of, the response. Resource mobilization, I would say a lot about this, especially in Ethiopia, where resources scarce, because we mobilized at least government finance somehow in billions, but that was not suffice. There is a need to mobilize different finance from multilateral and bilateral development partners in different mechanisms. And I also acknowledge the contribution of GOHi in this, because at least more than 60 surveillance officers were recruited and deployed to various types of sites and regions in Ethiopia and doing, the surveillance work. So we use such kind of, support financially, technically from different partners, and private organizations and social institutions also did their significant roles. The public itself, because for various reasons, business and incomes and the livelihood of many were put on scale, in challenge. So during that, the mobilization of resources from those entities would help. And it's good also to mention the contribution of the Ethiopian diasporas, scientifically supporting, the response in material, financial, and others. So we have used at least all possible means to mobilize, the necessary resource. In terms of facility readiness, these are also something that we could at least share as a good example, because we have limited, facilities, but repurposing of large space into treatment centers can be taken as a good example. Completely shifting certain hospital to be dedicated for COVID response. That would have its own at least effect to compromise, the routine health service. But at least we tried at least to have at least plan A, B, and the use of also other big convention centers for this purpose, and establishment of field hospitals, and at least mobilization of ICU facilities, including mechanical ventilators. If you remember, that was also a big issue in US, where we at least expect having of big technologies, and most manufacturers at that time, their priority was for their national community or people, and that would also has given a challenge for countries like Ethiopia. But at the beginning, we were having roughly 300, 400 mechanical ventilators, but in due course, we managed to have more than 1,000. The same is true for oxygen capacity. These days, many hospitals have their own oxygen production center, but during that time, we're having just 2 or 3 oxygen production center in Ethiopia. PPE production, that's a critical part during the first phase of COVID, let alone to Ethiopia. That was a big challenge in US. Most of the production sites are in China. So we ought at least to have our own means to address this problem. And thanks to the clear direction, the incentive given by the government, with the discussion that we had with various industries in Ethiopia, they repurposed the industry production, and they have started at least produce PPE, including also homemade production of PPE as well. So these are also some of the pictures showing, how big convention or, you know, thank you, Laura. Again, sorry for the technical inconvenience. So we used at least the health, I mean, the personnel at the Ethiopian Public Health Institute, I mean, the Ethiopian airline to fix, you know, malfunctioning ventilators. So that's, I mean, how we use some of the resources that we have in the country for COVID response. And the lab testing is also a good example. You know, the first case was diagnosed by sending, you know, the samples to South Africa. But just in a week period, we have started, you know, the first diagnosis at GOHi. But in few months period, in 9 months period, we, you know, increased the number from 1 to 65, and almost as we speak, in the last at least phase of COVID, we reached out at least to have, you know, 83 testing machines all over Ethiopia. We have not procured at least the machines during that time, and most of these machines are mobilized from different sectors, from agriculture, from universities, from research institutes, and we mobilized and at least used, you know, the available capacity for COVID response. And that's also a good experience how available resource that we have at hand could be used for such kind of problems and challenges. And regular update has been given also for the Prime Minister office for various reasons. One thing is there is a need to, you know, give update for the government leadership, but more importantly, there are different platforms that the politicians would have. So they use that mechanism at least to convey message for the respective, you know, regional president and others, because we are using federal systems where each region has its own autonomy, so that the engagement of the political leadership is very critical. Sometimes there are areas where, you know, the scientific people wouldn't make. So for that, we on regular basis, we provide, you know, the readiness of each region in terms of different you know, domains to the Prime Minister office, and sometimes we also convene discussions with the president. So you can see at least some of the figures that clearly show the readiness of different regions and also in aggregate as well. And modeling was also one of the capacities that we have built using, you know, the COVID as an opportunity, especially at the Ethiopian Public Health Institute, the availability of National Data Management Center. I also extend, you know, big appreciation for the Ethiopian diasporas here, because there is a need also to have, you know, at least knowledge, advanced knowledge for that. So we established that, and we had also very frequent meeting discussions with the Ethiopian diaspora, different universities, and also the facilities that we have at GOHi, and at least forecast the anticipation of the country if would not, you know, follow or adhere with a non-pharmaceutical intervention. So this is also the evolution of the COVID-19 situations in Ethiopia, starting from, you know, 30 March 2020, where we identified the first case. And we have also, you know, passed through several, you know, campaigns, you know, effective campaigns. And for sake of time, I wouldn't say a lot, but at least if I say just a point for combat, we call it combat, with the aim to enhance, you know, the testing capacity. Just before this campaign, the country's capacity to undertake COVID tests was less than 2,000. But after this campaign, we have reached out, you know, 20,000 per day. So the significant campaigns are really resulted to have a positive effect for COVID response. And these are all this journey are not, you know, free from challenges, and these are not also the only challenges that we faced, but at least the core challenges that we could at least share. Impact, you know, social, economic, and political. So no need to describe more, because if COVID impacted, you know, the developed countries socially, economically, politically, you can at least see its effect for countries like Ethiopia. But I would say our response is somehow also better than in some of at least the developed countries, I may be biased, but at least from the figure, from the outcome, one could say that. And pandemic fatigue, because whenever you do things frequent time, there is a tendency to have fatigue. It also resulted with economic and other factors, but this needs to be also considered. Misinformation, misconception was also something that need to be mentioned, even though we have at least aggressively working on risk communication. Still, there were also some time that we have been challenged. Other competing priorities, as I showed you at the beginning, COVID is one problem. We have so many problems in Ethiopia. So despite having those problems and mobilizing the resource, giving attentions, and doing the response would be super, but need to consider other emergencies as a factor or as a challenge. Essential service compromised, obviously, because we mobilized the limited resource that we have for COVID response, so that would have at least a negative effect, and some also compromise routine business, the routine care system. And global giant companies and their priorities would be considered as a big problem. And yeah, there are, events, times that we may not, forget in the entire of our lifetime, especially when you feel that almost 110 million inhabitants or the population of Ethiopia is behind the response, and the fate would be determined with that. And while we know, the remedies, and if we don't have, the capacity and the possibility, opportunity to get that, very painful, but using different mechanisms, approach, it was tried at least to overcome that. So maybe just to see how the response in Ethiopia looks like before and after, and also in comparison with a response elsewhere. For example, school closure, we intervened that, timely, and that would also have its own impact. And workplace closure. So we have not actually, one of the good things for the Ethiopian response is we're not, we didn't do things just or adopting considering the experience of other countries into account, but we considered the Ethiopian context into account, and we evaluate and weight the pros and cons, and we modify and adapt the situation, the response with the context of the country. So one of the things that we did was also, and the closure of workplace is in realizing the country's context. And cancellation of public events, we're also doing that well. And restriction of public gathering, you can see in the beginning and later on, and almost in terms of that, the country is one of the best performing countries globally. This is clearly depicted on the picture. And stay at home, we consider the Ethiopian context into account, because sometimes if you declare that for many households, that would be a death sentence. So it's hard to implement. So we tried at least to modify that based on the surveillance data that we get. So if we find certain communities, for example in Addis, having of a higher transmission rate, in that case we just block that community for some days, and while we provide food and others for that community. So these are the way how we can at least intervene with the resource and context we have on the ground. And this is also the restriction of movement, how we work it. And if we consider also some of the, the index, the matrix that clearly show how we better perform, for example, this is a stringency index, considering, the different, at least activities and response we have done, including, physical distancing, restrictions, and others into account. So we are at least among the countries in Africa with a higher stringency index. This is also the same. And you can also see the daily test or daily new confirmed cases. Ethiopia was also next to South Africa, and sometimes Morocco, Ethiopia, South Africa, the countries at least managing to diagnose, many to do testing at larger scale. The South Africa is very unique in terms of technology readiness. They diagnosed, much higher than Ethiopia, but at least considering other sub-Saharan African countries, we at least performed well. And that's also has been indicated by the COVID test per 1,000 population. And the fatality rate, that's also attributed with population that's size that we have. And also the more you test, the more you get, and the more you might have also the, the fatality rate. But at least in terms of mortality, we are also in good shape. And coming to the good experience to be shared. So resource mobilization and public participation is very critical. So it's not, what matter not would be, having of money, technology, as we have seen at least the challenge and the complexity of COVID response in places like US and Europe, but at least resource mobilization, and if you engage also the public, you can at least do better. Use of available resource and materials, as a good example is lab. We're not in a position to buy, PCR machine at that time. If we have the money and if we go to the market, even that was not the time to get things easily, but at least we mobilized, the available resource. Use of universities, private hotels for quarantine needs to be also counted. Engaging religious leaders, as I said, churches, mosques were closed for some time, but at least as a compensation or at least as a plan B, there were also live transmission from church, mosque, that individuals would attend, their religious ceremony and ritual activities while being at home. So this kind of experience could be also shared. Local production of NPIs, just repurposing the industries that we have, though we have limited, could be considered. Directives based on the context of Ethiopia. If you remember, US and Italy are the countries initially banned their travel to China. But Italy and US are amongst the countries highly affected by COVID response. So our directives and measures are in the context of Ethiopia. Whole government approach could be also considered as a good example. Public trust, more importantly, I think I mentioned that earlier. And the having of food banks, and we just know about many banks, but we also established the sense of having food bank, because we created that platform so individuals could share what he or she would have, and systematically we share those resources for individuals who are in need of. So these are, I think, considered as a good example. For future considerations for Ethiopia, integration of COVID-19 response is very critical, because if we continue like that, it highly compromises, the routine health system. So that now integration is a critical issue, and this process has been already started. Decentralization of the response is also something that we have taken as a lesson. Vaccine expansion, because the introduction of vaccine now changing, the paradigm. Minimize dependency and enhance self-sufficiency is very critical. One of the things that we learned from COVID is, each country gives its priority for its own citizens. So in that case, Africa would at least learn from that, and at least do things either at country level or at least at regional level to build, their own capacity. Capacity building at various level needs to be also considered. For global considerations, global solidarity is very critical because, COVID started from Wuhan, China, but, reached out almost all countries in the world. So that has given also a good lesson. So something could happen somewhere also, there is also a say, a threat somewhere is a threat everywhere. So by the same token, there is a need to build global solidarity, equity, fairness, and also to develop trust, because one of the challenge and also the gap that COVID left is, lack of trust among countries. So this to be sealed, joint capacity building activities at global, continental, country levels. More importantly, investing on preparedness activities, because it's quite costly to be, to respond for various emergencies, but the cost and also the implementation is quite easy if we do more on the preparedness side. And data and information sharing is also very critical. You can at least remember the dispute between China and other countries in sharing of data, and also even the implication of sharing data as well, because if you remember, Omicron was clearly reported from South Africa, but the moment South Africa reported that almost most countries, banned the travel and others there. So that type of approach, that type of, measures wouldn't, enable at least to help at least to overcome, such global challenge. So solidarity, trust, and information sharing, and balancing the influence are critical. And for Ethiopia, the critical part is strengthening further the public health emergency system at various levels, not only in the center, but also down to, facility level. And finally, the International Health Regulation, it was adopted initially in 1969. It has gone its own due course and reached the final one, 2005. It has resulted in many improvement, but it has its own limitation, because while having this document and ratification, we still challenged by the COVID response. So there is a need also to sit and revise its impact considering the lesson learned from COVID. And this is my last slide. And so globalization is something that we need, to take, whether we like or not. So frequent travels, movement is increasing from time to time. And if you see also the different evolution of different viral diseases, there are, times where we may not face this problem, but that couldn't, guarantee the presence of, new problems. So we lost almost 50 million deaths in 1918 due to Spanish flu. This number is almost more than what we lost during the World War II. But subsequently, there are different episodes of, disease outbreaks happened in 2019 COVID. Ultimately, and clearly, we'll face also disease X in the future. So the critical part now is, we'll face disease X maybe in 5 or 10 years period or next year, but there is a need at least to evaluate and see our readiness. And if we do so, I think we can better overcome and also respond for the outbreaks that we may also face in the future. These are, I think, some things that I want to share, and thank you very much. Over.
Thank you. Thank you so much, Dr. Ebba. This is, I was saying, thank you so much, Dr. Ebba. This has been so insightful. It's really honestly fascinating to hear from your perspective how all of this was handled at that level.
And we can go ahead and take questions from the audience now. And so if you could enter your questions through the Q&A, that would be wonderful. And it looks like we have a few to start with. So I'll start with this first question. What or how are were the efforts made to reach or convince people who were not willing to take COVID vaccines to be vaccinated? So I'll repeat that. How were the efforts made to reach or convince people who were not willing to take COVID vaccines or be vaccinated?
Yeah, I think that is a good question. Maybe I may not be the right person to respond this well, because the vaccination has started once I have left EPHI, but since we are also working in the FEM business, at least I could share the thing that has been done by EPHI, the Ministry of Health, and the regions. When it comes to COVID vaccination, there is a misconception, belief, thoughts, not only in Ethiopia, but also in most developed countries like US. But the irony is the vaccine hesitancy is not only on at least at community level. Even there is also a high vaccine hesitancy among health practitioners as well. So that has its own reason, because there were different thoughts, beliefs, discussions going on in places where the manufacturers are situated. And that has been also aired, and the information shared to places like Ethiopia, so that resulted, vaccine hesitancy, becoming, a big challenge. But as we all know, it is impossible to oblige individuals to take the vaccine, and the need to be done would be, to convince and inform them the benefit and make a showcase. And somehow, we have done that better as well. At the beginning, there were a high percentage of vaccine hesitancy, but at least key public figures, be it politician, or at least individuals representing the public, could be used as a model to enhance, the public trust. For that, the vaccination has been started from the higher government body, including also, the big public figures. So that somehow also tried to increase, the uptake, including also convincing the religious leaders, and televised that, and especially in places like Ethiopia, where religion would have a big place. So if there is at least a positive thinking and also practice among the religious leaders, there is a tendency also to follow that. And more importantly, there are also different campaigns being done in Ethiopia. We have reached at least 2 campaigns, and there is a plan also to conduct the third one in the near future. And those campaigns greatly also enhance, the uptake. In average, at least 15 to 20 million individuals have got, the vaccinations in each campaign. So we have used different modalities and approach, and that's why we currently have reached at least to reach out 43 million of individuals who have got the full vaccination. But in terms of at least the number of individuals who have got one dose or shot, it reached to 53 million. And based on the information that I have, is we have at least 20 million vaccination at hand. There is a plan at least to finalize those vaccinations in the campaign, in the third campaign, and that would also bring the country's vaccination status to roughly 70 million. So I think from the immunological perspective, if we at least vaccinate 60-70% of the population, that would have at least its own effect to minimize the COVID response.
Wonderful, thank you. So I think one of the questions was also, what is the current COVID-19 vaccination status in Ethiopia, which you just answered. So we'll move on to the next. So a question, thank you, Dr. Ebba. What is your view about the prediction of COVID-19 pandemic will cause in Ethiopia and the reality? What is the reason behind it or the cause? Okay. And then what is your recommendation for Ethiopia? It's the next X pandemics preparedness and response. And then what is the GOHi plan to support the country to control the infection from the source, like the Ministry of Agriculture? So I'm going to go ahead and display that because it was a multi-faceted question. So go ahead and so I guess the first question, what is your view about the prediction of COVID-19, the pandemic, the cause in Ethiopia and the reality?
Yeah, I think starting from 3 or 4 months period, COVID-19 incidents in Ethiopia significantly declined. As we speak, the incidence rate is almost below 1. So it has been kept there. It might have, several, reasons. One would be, the different, measures that we have taken, as what I have shared you. But more importantly, the massive vaccinations that we have done would have its own also effect. And this problem, viral problem, so there is also strain mutation, and that resulted to have a new mutant strains with different clinical and also difference in pathogenicity. So if we aggregate, that would also contribute at least for the current status of COVID-19 in Ethiopia. So for me, that's not also the features in Ethiopia, but that's also the case everywhere. Maybe the vaccination campaign or implementations would take at least a big share for places like US, but this is my views. But COVID might not be at such a big problems these days because at least we have be able at least to produce a vaccine, and we know also how to intervene that. The second question is
so what is your recommendation for Ethiopia to the next X pandemics preparedness and response?
Yeah, is that the second question or?
So recommendation for preparedness and response for the next pandemic.
Yeah. I think that part has been touched in the last slide, because if you remember my first slide, what we did just before, the advent of COVID-19, you can imagine having of 28 individuals facing challenges like COVID. How would have, done at least if we did not, do such kind of intervention in capacity building activities before that. That at least resulted to uplift, the readiness of the country to overcome problems like COVID. So by the same token, now we have, taken at least a big lesson. So translating, the lessons that we have, to practice is very critical. And that also encompass strengthening the public health emergency system in Ethiopia. That has been also started, but doing capacities at least needs to be given, strengthening, facilities at regions down to, facility level. At least in relative terms, the capacities that we have in the center is stronger in relative terms. So at least much attention needs to be given at least to enhance the public health emergency readiness capacity at regional and facility level, and enhancing also the laboratory capacity is very critical. You have seen, the role of laboratories in augmenting or addressing these problems like COVID. Without knowing, the specific etiology, we can talk about the response. So concomitantly, there is a need also to do more. For that, there are, some activities laying already the foundation, because there is a plan to establish at least the biosafety level 3 and biosafety 2 laboratories at EPH, and also in 15 regions in Ethiopia. That would somehow also enhance the laboratory system. Data management and communication is also very critical, and also having of data might not be suffice. We need to have also expertise who can play around with data, and at least to forecast, to make prediction, and also enhance the response activity. So if we at least put all all together, that would at least create a resilient public health emergency system in Ethiopia. So what I recommended for Ethiopia is to do this, and obviously that would also need to have finance. So there is a need also to have at least allocation of finance from the government and also from other partners. Maybe the role of the Global One Health and the GOHi in the preparedness and also the strengthening process of the FEM system in Ethiopia. This is also something that we have been doing in the last 2 years period. We are significantly contributed in that. As you might know, the Ethiopian's public health emergency system stretched from the center only down to Warada level. So there has not been any FEM focals at facility level. So for the first time in the last 1-2 years period, we have tried at least to make a showcase. So we recruited almost more than 75 health personnel deployed in the different health facilities all over Ethiopia, except Tigray due to the current war. And they clearly attested the need to have a focal, FEM focal, designated for that activities at regional level, and that lesson learned and also showcase, I think, at least have taken by some regions. For example, Amhara region, they have started at least to recruit dedicated FEM officers at various hospitals, and Addis Ababa is also following that, and I'm sure other regions would follow that as well. This is on the surveillance part, and we are also working to enhance the laboratory system in Ethiopia. For example, COVID is one thing, but if we at least come across with disease X in the future, until recent times, the only sentinel site that we may use for this purpose would be the facilities that we have at GOHi. So that is not, the capacity that we seek from at least that we want to see in Ethiopia, considering the population size and also the size of the country into consideration. So for that, we significantly build the capacity. And for the first time, we have established the additional 4 regional molecular laboratory sentinel sites in the 4 regions, 1 in Adama representing the Oromia, 1 in Amhara, in Bahar Dar representing the Amhara region, and 1 in Arba Minch, at least serving the southern part of Ethiopia, and also on top of the facilities that we have at GOHi, 1 also in Addis, at least to serve the community better. So we increased at least the capacity of the country by 4-fold, which is a significant capacity building done by the Global One Health and the Global One Health initiative. So, and we are also engaged in human resource development because we are not involving robots. So there is a need to have, various development of human resource at various levels, and we are supporting the initiative of EPHI regions on that, and we have also done our own gap filling exercise and activities with aim to enhance the human resource development. So these are, I think, something that we can at least mention about what GOHi is doing, and this part also will be continued in the future. And since we are also building our experience in engaging public health emergency management, and if we get, additional finance opportunities in the future, I'm sure we'll also keep on doing and strengthening the system in Ethiopia in the years to come.
Thank you. And actually, just to add on to that, incorporation of like the source, the Ministry of Agriculture. I know at the facility level, our FEM officers do take part in regular meetings with the Ministry of Agriculture, to my understanding. We collaborate very closely with the Ministry of Agriculture when it comes to developing protocols. And do you have any other comments on that, or inclusion of the Ministry of Agriculture in other sectors?
Absolutely, absolutely. And COVID is a good example of attesting the need to emphasize, One Health approach. We're, mentioning some other diseases before, but now we have been challenged by COVID, and our response, as you see, not only by, the response done by, the Ministry of Health or the health side as such. There were big support and contributions from different sectors, including Ministry of Agriculture and Ministry of Education and other sectors as well. So COVID is, a classical example of, the need to implement, One Health approach. And, One Health, the concept itself is, relatively new. Not only in Ethiopia, it's everywhere. So, these days is echoing here and there. It's just, a few years back that the country adopted, the One Health strategy through the signature of different line ministries. And we have, a national One Health steering committee, which is chaired on rotation basis. That committee at least tried to enhance, the One Health approach in Ethiopia, but still there is a lot remains, and they need to be also supported. And having of such kind of, platforms in the centers wouldn't address, the implementation of activities in regions at facility level. So for that, there is a need also to strengthen the regional One Health platforms at regions, at various facilities. So if we do so, that would create, a platform where different ministries would come, talk, discuss, share information, share resources, and also develop a common plan. So having of those platforms and strengthen, those platforms implement on in regions would at least change the game.
Yeah, wonderful. That's an excellent answer. Thank you. And only because it's related to that question, I'll skip to this. Thank you very much for your excellent presentation. What are your thoughts on the One Health approaches to COVID-19 response, including virus diagnosis using veterinary labs?
Yes, I think, as I said earlier, we utilized all the laboratory facilities that we have in Ethiopia for COVID response, be it veterinary, be it research, be it intended for various purposes. We utilize that, and we greatly acknowledge for that. But most importantly, this, intervention, it's not a proactive response, rather it is a reactive one. So the critical part now is, should we follow the same path, the same rhythm, the same pattern when we face, disease X in the future? That's, the critical part. So instead of reactive response, there is a need to be, proactive. So for that, there is a need to have the platforms that I indicated earlier, and that platform would at least result to know the capacities that we have from the veterinary side and also from the health side, and also how the crosstalk would look like. I think the rabies part will be, a good example for this, because almost for many decades, the only rabies laboratories that we have in Ethiopia was the one that we have at the Ethiopian Public Health Institute. But a few years back, we established the first, rabies lab in Tigray, Mekelle, and also in Bahar Dar, with anticipation that there is a crosstalk between the veterinary lab and also the human lab. So we're doing, quite good in Mekelle because there were, a good crosstalk between the two sectors. That's, how One Health as an example. But we're also facing some challenges in other regions. So if we use certain kind of, disease as a good model and show this, the result, how efficient the result would be if we have such kind of synergy, I think that would be also a good lesson to do more and better when we face a new disease in the future.
Absolutely. Wonderful. I want to let Dr. Zalalem ask his question
Thank you.
into the room.
Thank you, Dr. Ebba, for a nice presentation, especially as an Ethiopian myself. I saw your strong leadership during that time, that very critical time that the country needs really strong leadership in resource limited setting. Somebody asked about predicting, the COVID-19 pandemic trajectory, but I want to go back retrospectively and look at the modelings that were done, which were predicting a lot of body bags, in Africa, all over the place, and a lot of diseases that didn't happen. At least the presentation, at least in part, explained why that didn't happen. But that is still an ongoing question, why Africa was not really vulnerable to COVID-19 as it was expected. If you could say a few more words on that, if you have any opinion, especially the irony of having that world-class airline, which you mentioned in most of the introduction event early on, were from countries abroad, especially Africa, I think mainly from Europe. And we've seen in Italy, for example, a significant number of diseases, which was not seen in Africa. So if you think other reasons that could explain the scenario apart from the social public health measure, which were taken in a place where there is a very limited resource, I think it's a very good lesson for the future. Maybe also, if you could comment, do you think the COVID-19 pandemic is over? I heard a few weeks ago, I think President Biden said that statement has been a controversy all over. And as a person who have been at the forefront and probably have a look of the African response, if you have anything to add on that line, I would appreciate that. Thank you so much.
Yeah, thank you so much, Zalalem. Two good questions. The first one is, I may not have, the one answer for that, because there are different factors why COVID has not shown, its detrimental effect in places like Africa. But there is a need at least to critically see the assumption and plausible factors contributing for that. Initially, there were an assumption from most developed countries that there were many diseases, but due to the poor surveillance capacity in Africa, most of the problems might not be captured. That was the case, and in Ethiopia we did a very good assessment for that, because yes, obviously our surveillance system would have its own limitation, very tough to reach out all the population. But considering the Ethiopian context into account, if someone died, there are designated cemeteries, be it from the Christian sector to Muslim. So we provided that assignment for Addis Ababa University team and others, and they progressively follow the death pattern, the number of diseases, and also cause of diseases, and compared with the death data that we have in the previous years. So that would at least tell us that there were no many diseases that we missed due to the surveillance gaps in Ethiopia. I would say before US put some interventions at airports, we started that activities at Bole International Airport 2 or 3 months ago. due to the Ebola problems, and especially one of the controversy was to impose banning for flight to China. For Ethiopia, that would be suicide, because almost all our goods or many things of our activities would import from China, including the medications and medical products as well. So it's not strategic, to impose, travel ban for China, unlike, most countries did. Rather, what we did was we identified countries based on the data we often get from WHO and other information source. We evaluate their surveillance and also the burden of COVID-19, and we categorize countries based on their risk strata, and we consider special treatment and intervention for those travelers coming from certain countries. For example, for China, there is a mandatory, quarantine. So anyone who would come from China needs to be quarantined for 2 weeks period, and he or she needs to get also COVID test before leaving, the hotel or the quarantine place. So that would at least help to contain, if at all, there is, importation of COVID-19, through travel. But the other factors need to be also considered, like weather, genetic factor. There are, many issues that we need at least to count, but that shouldn't at least undermine the robust response made by most African countries, as opposed to the response that we have seen in other countries. One thing is, for example, in US, one of the challenge, in my view, is not lack of resources, not the initial introduction of vaccination, but the political system wouldn't allow, to impose one direction that could be, clearly go down to facility. Each region has its own autonomy. So some regions would decline to use mask. So there is no such kind of, practice and alignment in place like Ethiopia, including China. So if you, have state of emergency, there is a need to go down and be implemented. So that somehow also has its own spillover effect for why the COVID response, or at least the COVID implication, is grave, at least in US and countries like Italy. Maybe the second one is really COVID-19 is over. I think Ethiopia would be a good example for that. For me, it is not strategic these days to do well more COVID-19, because we have other problems, challenges that are, kill many Ethiopians. So at one time, we were not knowing much about COVID, and we tried at least to mobilize all our resources and intervened. And now we have a vaccination, and we know also the magic bullets for COVID. So it is just, immunology. The first immune response is weak, not quality. In terms of time, it has taken, some time to develop. But the second one is robust. In terms of quality, is better. So by the same token, we at least have developed a sort of experience for COVID. So I'm not saying that we completely, close the book, but at least we can integrate the COVID response with other diseases without compromising other problems. But if we do more on enhancing, the vaccination, and if we closely follow also the Sentinel site and other surveillance data, I think minimizing the efforts that we have been doing on COVID need to be at least revised, especially for countries like Ethiopia.
Wonderful, thank you. And I know we're getting close on time, so we'll just take one more question. I apologize, we won't get to all of these wonderful questions, but thank you for submitting them. And many of them have been actually answered through your responses. So we'll just, one last question. How can biotechnological tools be used for the development of COVID vaccine in Ethiopia?
Yeah, that's also a good question. I would rather revise, the question, not focusing on COVID-19 because somehow we have, managed to vaccinate at least a large number of population in Ethiopia, and in terms of coverage globally, I think we are in good shape. But there is a need to enhance the capacity of the country in at least having of such kind of technologies. For example, I remember one company who is a good client of us, giant world-class company, having of lots of machines for HIV-related activities in Ethiopia. So we had a discussion at least how to get, the kit for COVID response in the first phase of COVID. The pressure at that time. So we tried at least to push and make negotiations with the presence of Her Excellency, the Minister. But I always remember, the phrase they used. Well, the companies usually has their own, priorities. So our first priority is X country. Our second priority is this region. Maybe Africa is the third one. So in terms of finance, so that would give us at least a good lesson how need to be done in the future. So that's why we tried at least to have discussions with other companies like BGI. And in due course, I think I did not mention that, we managed to at least assemble the COVID-19 kit in Ethiopia. So that's also what we have learned in due course and intervened. So such kind of introduction of technology and enhancing self-sufficiency is very critical. And that's also what we have learned from COVID. But in terms of, vaccine production, the technology is complex. It needs, a large, amount of money, at least to mobilize either from government or from private firm. In terms of technology experience, if Ethiopia would manage to do that, would be good. There is, a discussion, but these days the focus from the government side is to enhance the pharmaceutical industry. But I'm sure that at some point we'll touch also the vaccine companies as well. But at least rather than, each individual, country would have their own vaccine capacity, because since we are having resource problem challenge all over Africa, we can use at least continental platforms to have such kind of capacities, for example, through Africa CDC. So if we have, one company that would give or provide services for the southern part of Africa based in South Africa, that would be okay. If we have one in the eastern, in the west, so that would help at least to share resources and to at least maximize the resources and would be also ensure sustainability. And I at least advise to use, or follow that approach.
Thank you. Thank you. Such wonderful answers. Yeah, so I think, thank you again so much, Dr. Ebba. Has been so insightful. And again, it's such a pleasure and an honor to have you here with us. And thank you to our audience for all of your wonderful questions. We are at time. We do hope that you'll be able to join us in December. Our next webinar will be December 15th. And we'll be hearing from Dr. Wanasin Cabreyas and Dr. Lonnie King discussing One Health leadership. And stay tuned on our website where we'll have more information posted about that. But again, a huge thanks to Dr. Ebba for sharing this wonderful information with us. And with that, we will close. So thank you so much, everyone. Have a good rest of your day.